Hi everyone, I'm Dr. C Gupta, Clinical Director and Chief of Vascular Surgery at Care Hospitals, Banjara Hills. We have a very unique department comprising of vascular and endovascular surgeons, interventional radiologists, podiatric surgeon, and psychologist to be able to provide comprehensive and holistic care to our patients. One of the common problems that we deal with is renal failure. So while we don't treat renal failure directly, we create vascular access or AV fistula, which is considered to be the lifeline for these patients on hemodialysis. In, let's say, a decade or two back, dialysis meant literally the death warrant for a patient. But now we have patients who are on dialysis for 5 years, 10 years, 15, and even 20 years. Some of our own patients that we've created vascular access are on dialysis for over a couple of decades now. So, Dr. Rahul, when it comes to creating vascular access, despite all the problems, we see that sometimes the accesses malfunction or fail. What are the common reasons why they don't function or malfunction?
Well, the most common reason why they fail is the narrowing in the vein. So as we know, the veins are not used to such high flows and there is repeated puncturing for dialysis. So they tend to develop narrowing. That is the most common cause for the fistula failure.
And of course, if a patient does not have a good quality vein or a good quality artery, that may even prevent maturation and even initial use of the fistula.
Yes, so that will be the most common cause that will say for early failures of fistula or the non-maturation.
So if a patient is on dialysis and the dialysis has been going on well, what are the signs that indicate that the fistula is getting into trouble now?
So that's a very important part. What a patient as well as everybody taking care of that dialysis patient should learn.
So you mean the dialysis technicians and nurses?
Yes, right. So the dialysis technician, nurses, the patient on dialysis as well as their attenders who are taking care of that patient. So early signs that you can watch for are when you touch the fistula, if the thrill has become weak or it has become more of pulsatile, that you don't feel the vibrations but just feel a pulse, then that is the early sign that you can notice while examining a fistula. Others are any alarms that you see or notice whenever the patient is on dialysis. Decreased flow rates or increased in the venous pressure. These are the two that they routinely watch and note on every dialysis. With this, they can identify a failing fistula early.
So sometimes we get patients who've been on dialysis and they say, "Aaj needle lagane mein bahut mushkil hui." Is that an indication that fistula could be failing?
It could be there because it can be narrowing somewhere there that is causing decreased flow or increased pressure. So that can be one.
So reduced flows, increasing pressure, these are indications that a fistula could be failing and that you need to see a specialist so that the fistula can be fixed. Now, what are the most frequent complications that you see? Is it blockage? Is it infection?
So in our practice, we see more of blockages and we treat them well. Other complications like swelling or infections are less compared to blockages.
Sometimes we see a very pulsatile vein, which indicates that the pressure in the vein is very high, and these patients typically get ulcers where the needles are being punctured.
Yes, so one of the reason for that is narrowing of the vein higher up, so the vein which is below is not able to pump the entire blood out. That leads to its increase in size, dilatation, and whenever they are puncturing, that area tends to become more and more enlarged. So infection chances are high, and because of the pressure, the bleeding time is increased.
Today I saw one patient who had a dialysis yesterday, and I saw that the puncture point was a new one very close to a major artery, and once the needle was removed, he developed significant swelling and pain at that point. What could that be due to?
So that could be one due to a double puncture. So usually whenever a needle is inserted in the vein, if it goes through the posterior wall or the wall that is deeper, and while removing the needle, that is the point where it starts bleeding and it leads to pain as well as swelling.
Can arteries be punctured accidentally?
Yes. So if it, as you mentioned, if the vein is very close to the artery, and the moment they remove the needle, then the bleeding is from the artery. That leads to bleeding, and sometimes either a hematoma or what we call a pseudoaneurysm, in which there is a continuous blood coming out from the artery and then going back.
So if a patient comes with a problem like the flow is less, or difficulty in puncturing, or high venous pressures, prolonged bleeding, can we do something to help these patients?
Yes, absolutely. So for these patients, we can first do a complete fistula mapping from their inflow, the anastomosis, and the outflow of the circuit. So we can identify if there is any narrowing in the vein or there is any narrowing in the artery, and then treat it accordingly.
So typically what you are describing is typically that we inject contrast, and like doing an angiogram, we image the fistula.
Initially we can do the mapping with the help of an ultrasound, so that we do routinely in the clinic. And if we found out that there could be a possible narrowing somewhere, then we go ahead, do an angiogram and treat the lesion at the same time.
Okay. So yesterday I saw a patient who said, till the last dialysis my fistula was working well, I could feel a good thrill on it. The next day I could not palpate anything, could not feel any thrill or vibration. What does that indicate, and can you do something to help such patients?
Yes, definitely. I think this is one of the most common scenario that we see in practice. This could be narrowing of a vein very close to the fistula, or what we call it as juxta-anastomotic stenosis, where there will be continuous thrill, but the vein is gradually getting narrower and narrower, and one fine day it just completely blocks. That day the thrill is absolutely lost. Before that there was a very good thrill. It's the common presentation how a patient will tell us.
So if I were to say the fistula is now thrombosed, that is a complete clotting of the vein, what are the techniques that you can use to open up these fistulas, and how successful are you in opening up these fistulas?
Yes. So once a fistula is failed, a common reason is clotting inside due to an underlying lesion. So treating these consists of two aspects. One is to remove the clot, at the same time treat the lesion or the narrowing somewhere which is causing it. The causes caused the clotting. So we can clear the thrombus or the clot by open method or by complete endovascular method, in which we clear off the clot and then we can treat the underlying lesion or the narrowing with fistuloplasty.
तो जैसे बोलते हैं कि प्रॉब्लम को जड़ से खत्म करना है, तो just removing the clot is fixing only part of the problem. It will reclot. जो उसकी जड़ है, that is the narrowing in the vein or the stenosis, that needs to be fixed with a balloon angioplasty or a fistuloplasty. That is what will keep the fistula open.
Yes,
am I right?
Yes, absolutely.
Okay. So does a patient coming early to you with a failing fistula versus a patient coming late after a fistula is closed, which one would you prefer to treat? And which patient will fare better in terms of outcomes?
Well, absolutely what any common person would say, a failing fistula has a higher success rates if we treat them. And I would say the major advantage of treating a failing fistula is they don't need a catheter, because
Yes.
once the fistula is clotted, then they need an access first for dialysis. So they eventually end up with having a catheter either in the neck or in the groin. Then the surgery is done to revive that fistula. Then they can use the fistula. But if you are coming early with a failing fistula, you are fixed, the fistula is fixed, and the next day you can use the fistula for dialysis.
Very nice. So there are times when we consider if there is enough length of vein available and there is a very narrow segment of vein close to the anastomosis of where the fistula is made, can you consider making a fresh fistula higher up, or what we call revision of fistula?
Yes, so this is one of a common solution for narrowing very close to the old fistula. So if the vein is narrowed very close to the fistula, example, if you see my watch, here is the fistula and the narrowing is just above it, we can do a revision or make a new fistula just above it, so that we are using the same vein, the same artery, just making a new connection. And big advantage, again, he doesn't need a catheter.
Yeah. So I think what Dr. Rahul is trying to emphasize is come early, get your fistula fixed early if there is a problem. Not only is it easier to treat, not only are the results better, it's probably also more economical, and you avoid any central lines or catheters which can damage the veins, which itself is a major problem which can lead to failing fistulas or problems in the hand. So Dr. Rahul, if there is one message that you would like to give to patients who are on dialysis with fistulas, what would you like to tell them?
Well, fistula is your lifeline. My motto will be maintain your lifeline for a lifetime. Come early, identify a failing fistula, get it fixed. You can use one fistula for your lifetime.
I think that is very well said, and that is what patients would love. The first fistula, well made, working for a lifetime, that is what any patient would want, that is what any vascular surgeon would want, and of course the nephrologist would be so happy too. And I think to do this, follow simple care that we tell you. Surveillance is important by the patient, by the dialysis technicians and nurses, and with periodic visits to the vascular unit where the fistulas can be evaluated to look for any early problems that can be treated easily. Thank you. Thank you, Dr. Rahul.
Thank you so much.